Welcome back to the deep dive. Today, we're doing something a bit different.
A bit more focused, you mean?
Exactly. We're putting on the serious face. This isn't just a casual chat through some papers. We are in, full-on exam prep mode.
I can feel the tension already.
Right. I want you to imagine the scene. It's, say, 2 weeks before the MD anesthesiology finals. The coffee's gone cold.
The anxiety's definitely not cold.
Oh, it's red hot. And the books. The books are just piled up like a fortress around you. We've got the whole stack here.
I know that feeling all too well. It's that specific mix of adrenaline and impending doom.
It is. And today, we're specifically targeting the pattern of the Gujarat University exams. We're talking the heavy hitters. Miller, Stolting, Guyton for physio.
And of course, the Bible.
The absolute Bible of pharmacology in India, KD Tripathi.
You cannot pass an Indian medical exam without quoting KDT. It's practically the law of the land.
So our mission today is to take all that incredibly dense material and just synthesize it, turn it into a streamlined, high-yield audio guide, and we're tackling a doubleheader. One that is, it's absolutely essential for the theory papers, especially those 20-mark long answers, and for the Viva.
Let me guess. Neurotransmitters and brain death.
You got it.
It makes sense. They might seem completely distinct at first glance, but if you really think about it, they're the bookends of our specialty.
How do you mean?
Well, one deals with the very spark of neuronal life and communication, which is what we manipulate every single time we induce anesthesia. And the other deals with the definitive cessation of that life and all the complex physiology that follows.
That is a brilliant way to frame it. The spark and the silence. Okay, so here's the dynamic for today. I'm the stressed exam candidate. I've read the books, but my brain is just a fog of details.
And I'm the senior faculty, the professor who's seen 1,000 students like you.
Yes. You're going to guide me through the must-know points, help me structure my answers so I hit those specific keywords the examiners are just waiting to hear.
I'm ready. We'll focus on clarity, mechanisms, and, most importantly, exam strategy. How do we get you those extra marks?
Perfect. So let's split this dive. Part A, the physiology and pharmacology of neurotransmitters.
And Part B, the physiology, diagnosis, and management of brain death.
Let's dive straight into Part A, neurotransmitters.
It's a huge topic. Where does your brain usually get stuck?
Honestly, it's the framing.
Mm-hmm.
Right at the beginning, if I get that 20-mark question, classify neurotransmitters and discuss their role in anesthesia, I just freeze up on the introduction. How do I define a neurotransmitter without it sounding like I'm just reading from a dictionary?
You need to be precise but natural. Think of it structurally. A neurotransmitter is, first and foremost, a chemical mediator.
Okay, a chemical mediator.
Where is it? It's released into the synaptic cleft.
Yep.
Why is it released? In response to an action potential.
Okay.
And what does it do? Its whole job is to transduce a signal to the postsynaptic neuron.
Chemical mediator, synaptic cleft, action potential, transduction. Got it. That covers the basic definition.
Yeah.
But I probably need to mention where they work, right? The bigger picture.
Briefly, yes. You should mention their ubiquity. They're the fundamental language of the central nervous system, the CNS, for processing information. But don't forget the peripheral nervous system, the PNS.
So motor control, autonomic function.
Exactly. They're controlling muscle contraction at the neuromuscular junction and regulating all your autonomic functions. They're everywhere.
And then the so what for us, the anesthetic relevance.
The so what is that everything we do, anesthesia, ICU care, pain management, it's essentially the practice of applied neuropharmacology.
We're pharmacological manipulators.
That's the perfect term for it. We are either inhibiting the excitatory transmitters or we're potentiating the inhibitory ones. Think about it.
Right.
You give propofol to induce sleep, fentanyl to blunt pain, rocuronium to relax muscles. Every single one of those drugs is targeting these chemical messengers or their receptors. That's our entire job.
That really sets the stage. But to really impress an examiner, especially one who worships KD Tripathi, you need the criteria, don't you? You can't just call any random chemical a neurotransmitter.
It has to earn the title. That is absolutely correct. There are 4 classic criteria you need to list, word for word if you can, to get full marks on that intro.
Okay, let me try and recall them from my notes. First one, presynaptic presence.
Correct. The substance has to be present in the presynaptic neuron, and usually it's sitting right there alongside the enzymes that are needed to synthesize it.
So it's not just floating around in the blood, it has to be made and stored right on site.
Manufactured and stored on site, exactly. What's number 2?
Release. It has to be released when the nerve is stimulated.
Yes. No release, no transmission. And typically that release is calcium dependent. The action potential hits the terminal, calcium channels open, calcium rushes in, and poof, the vesicles fuse and release their contents.
Okay. Third is identity of action. This one always sounds a bit fancy.
It just means if you apply the chemical artificially exogenously, it should do the exact same thing that stimulating the nerve does.
So if the nerve makes the muscle twitch.
Then squirting the chemical on the muscle should also make it twitch. Identity of action. Simple as that.
Right. And the fourth one is about antagonism. Its effects have to be antagonized or potentiated by specific substances that also mess with nerve stimulation.
Precisely. If Curie blocks the nerve signal at the NMJ, it better also block the chemical you're claiming is the transmitter there.
Which is acetylcholine.
Exactly. So if you list those 4 criteria, presence, release, identity of action, and specific antagonism, you have set a solid scientific foundation. You've shown the examiner you're not just memorizing, you understand the basic science.
Okay, now looking at past papers, this topic is everywhere. Long answers, but also short notes on GABA receptor or NMDA receptor. We need a classification system, a good one.
For the exams, do not invent your own. Stick to the examiner's favorite, which almost always comes from Guyton or a similar standard textbook. It divides them into 2 broad categories based on their size and their speed.
Right. You've got the small molecule, rapidly acting transmitters, and then the bigger, slower ones, the neuropeptides.
Let's focus on the small molecule group first, because that's where we live as anesthetists. It's divided into 4 classes. Walk me through class 1.
Class 1 is just acetylcholine. Sits there all by itself.
The one and only. The primary cholinergic transmitter. Good. Class 2.
Class 2 is the amines. This is the stress gang, right? Norepinephrine, epinephrine, dopamine, serotonin, and histamine.
Correct. They act fast, but they often have longer-lasting, more modulatory effects than Class 1. What about Class 3?
Class 3 is the amino acids. This is the big league for the CNS. This is GABA, glycine, glutamate, aspartate.
These are the absolute workhorses of fast synaptic transmission in the brain, the main on-off switches.
And Class 4 is the odd one out.
Very odd.
Nitric oxide. And no.
Why is it the odd one out?
Because it's a gas.
Yeah.
It's not stored in vesicles like the others. It just diffuses.
Exactly. It's synthesized on demand and diffuses instantly across membranes. It breaks all the rules. Now, that's the chemical classification, but for a clinical viva, there's another classification that's arguably more useful.
Functional. Excitatory versus inhibitory.
Precisely. So let's do a quick fire drill. You're in a viva. They ask you, what is the major excitatory neurotransmitter in the brain?
Glutamate. No question.
And the major inhibitory one in the brain?
GABA.
Good. What about in the spinal cord?
That's a classic trick question. It's glycine. Glycine is the major inhibitor there.
Excellent. And you have to remember that some are variable. Acetylcholine and norepinephrine are the chameleons of the group.
Meaning they can be excitatory or inhibitory.
It depends entirely on the receptor they bind to. So EC is excitatory at the neuromuscular junction, right?
Nicotinic receptor makes muscle contract.
But it's inhibitory at the vagal nerve endings in the heart, acting on a muscarinic receptor. It slows the heart down, same molecule, 2 different jobs.
Okay, that's a key point. Let's drill down now. I want to hit the high yield points for the specific transmitters that we really need to know. Starting with acetylcholine.
Okay, where do we find it?
Everywhere practically. Motor neurons for skeletal muscle, that's the neuromuscular junction. Preganglionic autonomic neurons. Postganglionic parasympathetic.
Yeah.
And also in the CNS for things like arousal and memory.
And the anesthetic relevance is obvious.
It's the target for all our neuromuscular blockers. Our NMBs. We compete with AESH at that nicotinic receptor to paralyze the patient for surgery.
Right. But don't just stop there. What about its central effects?
You mean like with anticholinergic drugs?
Exactly. Think about scopolamine or atropine. They cross the blood-brain barrier and block those CNS arousal pathways. That's why patients, especially the elderly, can get confused or delirious after a dose of atropine. It's not a benign drug.
You're disrupting the cholinergic wakefulness system. That's a good point. Okay, next up, the catecholamines, the stress transmitters.
Let's start with norepinephrine. Where's it from?
Secreted by the locus coeruleus in the brainstem.
Locus coeruleus literally means the blue spot. A tiny little nucleus, but it projects everywhere. It controls mood, wakefulness. It's a key player in the descending analgesic pathway.
So it helps modulate pain processing.
It essentially tells the brain, pay attention, and this hurts less than you think.
Okay. Then there's dopamine from the substantia nigra in the basal ganglia.
And if you lose that, what happens?
You get Parkinson's disease. The rigidity, the tremor. which can be a nightmare for airway management. And we have to be really careful with drugs like metoclopramide that can worsen it.
Good clinical tie-in. And epinephrine.
Mainly from the adrenal medulla. More of a hormone, really. A major metabolic regulator.
Okay, what about serotonin? 5-HT.
It originates in the median rife of the brainstem. The books say it's an inhibitor of pain pathways in the spinal cord, but also controls mood and sleep. And clinically, it's the bad guy in postoperative nausea and vomiting, PONV.
Exactly. Which is why ondansetron, a 5-HT3 antagonist, is one of our most common drugs. You see, every drug we use ties directly back to this list.
Right. Which brings us to the king, the absolute king of anesthesia.
GABA.
Gamma-aminobutyric acid.
I feel like if I don't know GABA inside and out, I shouldn't even be in this residence. You'd certainly struggle to put anyone to sleep. It is the principal inhibitory transmitter in the CNS. Full stop.
And we love it because it's the primary site of action for our IV induction agents. Propofol, etomidate, thiopentone, and the benzodiazepines, they all work here.
They all enhance its function. We'll get to the receptor mechanism in a second. That's a goldmine for Marx. But first, let's contrast it with its opposite number.
Glutamate.
The yin to GABA's yang.
Glutamate is the workhorse of excitation, involved in something like 90% of synapses in the brain, absolutely crucial for learning and memory. But there's a dark side. The books warn about excitotoxicity.
Yes, this is pure pathology. If you have ischemia, say, from a stroke or a cardiac arrest, the ion pumps in the neurons start to fail.
Okay.
And glutamate just floods the system. It literally excites the neurons to death. Calcium rushes in, destructive enzymes get activated, and the cell basically digests itself from the inside out.
That's a terrifying thought. And clinically, which drug acts here?
Ketamine?
Right. Ketamine is an NMDA receptor antagonist. It blocks glutamate.
Exactly. So look at that beautiful symmetry. You have propofol, which boosts GABA. You're stepping on the brakes.
And you have ketamine, which blocks glutamate. You're taking the foot off the accelerator.
That is the fundamental duality of modern anesthesia. Inhibition enhancement and excitation blockade.
I love that analogy. It's so clear. And it leads perfectly into the next section, receptors. This is another area where I can get mixed up in the heat of a viva. Ionotropic versus metabotropic.
The key is to think about the speed. Ionotropic receptors are basically ligand-gated ion channels.
So the drug is the ligand.
The drug binds, the channel pops open, ions flow through. It is fast. We are talking milliseconds, instantaneous.
Okay, can you give me some examples?
The nicotinic A receptor, the GABA A receptor, the glycine receptor, and the glutamate receptors like NMDA and AMPA, all ionotropic.
So GABA is ionotropic. That explains why propofol puts you to sleep in one arm-brain circulation time. It's a direct door opening, no middleman.
Precisely. Now, metabotropic receptors are G-protein-coupled receptors. This is a whole different process. Much slower. The drug binds, a G-protein is activated on the inside of the cell membrane. Then second messengers like KMP or calcium get involved. It's a whole cascade. It's more about modulation than instant transmission.
So like the muscarinic AC receptors.
Perfect example. Think about giving glycopyrrolate or atropine to treat bradycardia. It takes a minute or two to see the heart rate climb. That's a metabotropic effect.
And opioids.
Opioids also act on G-protein coupled receptors, specifically the mu, kappa, and delta receptors. It's a slower modulatory effect on pain pathways.
That makes so much sense.
Okay.
But let's zoom in on the GABA-A receptor itself. This is a common short note question. It's a pentameric structure, right? 5 pieces.
5 subunits arranged like staves of a barrel around a central pore, usually 2 alpha subunits, 2 betas, and a gamma.
And the pore in the middle conducts chloride ions.
Correct. When GABA binds to its sites, that pore opens, and chloride, which is Cl, rushes into the cell.
Chloride is negative, so the inside of the cell becomes more negative.
Which is called hyperpolarization.
And that moves the resting membrane potential further away from the firing threshold.
So the neuron is less likely to fire an action potential. It goes to sleep.
Okay, now here's the nuance that I know the examiners love. The difference between how benzodiazepines work and how, say, barbiturates or propofol work. They don't do the exact same thing, do they?
Be very careful with your wording here. This is a critical distinction. Benzodiazepines do not open the channel directly.
Okay.
They bind to a completely different specific regulatory site at the interface between the alpha and gamma subunits. And what they do is increase the frequency of channel opening when GABA is around.
So they're just facilitators. They make GABA work better.
Exactly. They need GABA to be there. But propofol and barbiturates are different. At low clinical doses, they also potentiate GABA. But at high, toxic doses, they can directly open the channel all by themselves, even if there's no GABA present.
Ah, and that explains why you can overdose and die from barbiturates much more easily than from benzodiazepines.
Precisely. Benzos have a ceiling effect because their action is limited by the amount of GABA present in the synapse. Barbiturates do not. That is a distinction that gets you the honors marks.
Right. Okay, let's try and synthesize all of this into that big 20-mark essay, the role of neurotransmitters in anesthesia. Historically, we had that old Meyer-Overton lipid solubility theory.
The idea that anesthetics just dissolve in the lipid membrane and kind of, gum up the works, a very non-specific theory.
Right. But we've moved on from that. The modern view is all about specific protein targets.
The unified theory is out. Specific receptor targets are in. So to summarize the mechanisms of action for your essay, you'd list them. 1. GABA potentiation.
That's propofol, barbiturates, etomidate, and also the volatile agents. All of them enhance GABAergic inhibition.
Resulting in hyperpolarization. Good, 2.
NMDA inhibition, that's ketamine and nitrous oxide inhibiting the excitatory glutamate receptor.
And that's why ketamine is a dissociative anesthetic. It's not just putting you to sleep. It's actively blocking excitatory pathways between the thalamus and the cortex.
A completely different mechanism. And 3.
Don't forget glycine potentiation, especially for the volatile anesthetics.
Right, in the spinal cord. And that's what mediates immobility, isn't it? The reason patients don't move when the surgeon makes an incision.
That's the leading theory. The brain is asleep thanks to GABA, but the spine is paralyzed thanks to glycine. It's a two-pronged attack.
Before we wrap up neurotransmitters, let's just quickly touch on the clinical correlations, why it matters in the ICU. Hepatic encephalopathy is a classic example.
Right. A failing liver can't clear ammonia.
And the high ammonia levels in the brain mess with the whole glutamate-glutamine cycle. But you also get these so-called false neurotransmitters building up, like octopamine.
And what's the net effect?
Essentially, the patient's brain gets sedated by these toxins and an overall increase in GABA tone. They become confused, obtunded.
Good. What about toxins? Tetanus and botulism.
Right. Tetanus toxin is nasty. It travels retrograde up the axon into the spinal cord, and it prevents the release of inhibitory transmitters.
Glycine and GABA.
Exactly. So if you lose inhibition...
You get runaway excitation, uncontrolled muscle contraction, spastic paralysis, lockjaw.
Well, botulism toxin does the opposite. It works at the NMJ and prevents the release of acetylcholine.
So you lose excitation and you get flaccid paralysis.
Perfect. I think that covers part A. We have the definition, the criteria, the classifications, the deep dive on GABA and glutamate, the receptors, and the clinical correlations.
All right, let's take a breath. That was the micro level, the spark. Now we are zooming out to the macro level, the complete cessation of function, part B, brain death.
This is a high-stakes topic. In the exam and in life, you just cannot get this wrong. Diagnosing death is the ultimate responsibility.
So let's start with the definition. It seems straightforward, but I know there are important regional differences.
You absolutely have to distinguish between whole brain death and brainstem death.
Okay, so whole brain death is the model they use in the US and most of Europe. It's defined as the irreversible cessation of all functions of the brain. That includes the cortex and the brainstem. The whole thing is gone.
And brainstem death.
This is the UK model, and it's the one we largely follow in India under the Transplantation of Human Organs Act, or THOA. It defines death as the irreversible loss of brainstem function.
What's the logic behind that? Why just the brainstem?
The argument is that the brainstem is the seat of consciousness. It contains the reticular activating system, and it controls the drive to breathe. It controls the capacity for life itself. If that is gone, the person is dead, even if some random, unorganized electrical activity persists in the cortex for a short while.
Right, because if the brainstem is dead, spontaneous respiration has stopped, and the heart will inevitably stop beating soon after.
It is an irreversible and inevitable process. Now, in Aviva, they will expect you to distinguish this from coma and from a vegetative state.
Right, so coma is unarousable unawareness, but, and this is the key, brainstem reflexes might still be intact.
They might gag, their pupils might react. They're in a coma, but they are not dead.
And a vegetative state.
That means the brainstem is actually intact. They have sleep-wake cycles, their eyes might open and roam around, but there's no cortical function, there's no content of consciousness, no awareness.
And brain death is the final step.
Loss of brainstem function, plus apnea, the inability to breathe, plus, and this is the most important word, it is irreversible.
That word irreversible is the legal and ethical key. It allows us to withdraw fetal ventilation, or, if the patient is a candidate, to proceed to organ retrieval.
Now, for the physiology, this is fascinating and terrifying. The catecholamine storm.
Right, this is the story of the brain dying. Walk me through it.
Okay, so phase 1 is ischemia. You have a massive head injury or a bleed. Intracranial pressure, the ICP, starts to rise. Eventually, the ICP gets higher than the systemic blood pressure.
So blood can't get into the brain anymore. The brain is starving.
It's being strangled. Then comes phase 2, the Cushing's reflex. The medulla, the last part of the brain to die, becomes ischemic. It screams for blood flow.
How does it do that?
It triggers a massive planet-wide sympathetic discharge to try and raise the systemic blood pressure high enough to overcome the ICP. So you see this classic triad: hypertension and reflex bradycardia.
This is the catecholamine storm. The heart is just being hammered. You might see arrhythmias, ST changes, myocardial strain.
Absolutely. And finally, phase 3, the crash. The brain herniates through the foramen magnum, the cord infarcts, and you get a sudden, total sympathetic deactivation.
And everything just collapses.
Widespread vasodilation, massive refractory hypotension.
This is what we call vasoplegia. The vascular tone is just gone. And right alongside this, the pituitary gland fails.
Right. You get total endocrine failure, no ADH, so you get diabetes insipidus. They start pouring out massive amounts of dilute urine.
And they can't regulate their temperature anymore.
Loss of thermoregulation, so they become hypothermic. So you look at the patient, they were hypertensive. Now they're profoundly hypotensive. They're pouring out urine and they're cold. That clinical picture just screams brain death.
Okay, so you're the resident on duty. You suspect brain death. Do you just walk up and start testing reflexes?
No, absolutely not. There is a pre-flight checklist. You must satisfy all the prerequisites first. If you rush this part, you fail the exam. And in real life, you could potentially diagnose death in a patient who might have recovered.
This is a core exam area. Let's list them one by one.
Number 1, the coma must be irreversible and have a known cause. You can't diagnose brain death if you don't know why they're in a coma. If it's a mystery, you wait. You investigate.
Okay, number 2.
Number 2, no CNS depressants on board, no alcohol, no sedatives, no opioids, and absolutely no neuromuscular blockers. You have to check with a nerve stimulator to make sure they aren't just paralyzed.
I have seen residents try to test reflexes on a patient who was still on a vecuronium infusion. Don't be that resident.
Please don't. Number 3, no major metabolic confounders. You have to correct severe electrolyte imbalances, sodium, phosphate, glucose. Severe hyponatremia can cause a deep coma.
Right. And number 4 is crucial. Normothermia.
The core temperature must be above 35 degrees Celsius. Some guidelines even say 36.
Why is temperature so important?
Because severe hypothermia is a potent neuroprotectant and an anesthetic in its own right. It suppresses reflexes and it perfectly mimics brain death. You have to remember the old saying, they aren't dead until they're warm and dead.
Warm and dead. Got it. And number 5.
Normotension. The systolic blood pressure usually needs to be maintained above 100 millimeters of mercury. You can't test a patient who is in profound shock because their brainstem might just be ischemic from low blood flow, not actually dead.
Okay, the checklist is complete. We've done our due diligence. Now we can move to the clinical criteria, the 3 pillars.
Pillar 1, unresponsiveness, a deep, flaccid coma, GCS of 3.
Pillar 2, the complete absence of brainstem reflexes.
And pillar 3, the final confirmation, the apnea test.
Let's do the reflexes. In the Viva, they'll ask you to demonstrate these or describe them. You tell me the reflex and I'll tell you the anatomy it's testing.
Okay. Pupillary reflex.
Afferent is cranial nerve to the optic nerve. Efferent is the third, the oculomotor nerve. You shine a bright light in the eye. There should be absolutely no pupillary constriction.
Corneal reflex.
Afferent is the ophthalmic branch of cranial nerve V, the trigeminal. Efferent is the eventh, the facial nerve. You touch the cornea with a wisp of cotton. There should be no blink.
Oculocephalic reflex, the doll's eye maneuver.
You turn the patient's head rapidly to one side. Normally, the eyes move in the opposite direction to stay fixed on a target. In brain death, that connection is broken. The eyes stay fixed in the head and move with it, just like a painted doll.
And which nerves does that test?
The vestibular nuclei and cranial nerves, 3rd, 4, and 6. But, and this is a critical safety point, you do not do this if there's any suspicion of a C-spine injury.
Excellent point. Okay, next. Oculovestibular reflex, the caloric test.
This is the most potent stimulus for the vestibular system. You instill ice-cold water into the ear canal. Normally, the eyes will deviate toward the cold stimulus. In brain death, nothing happens. The eyes remain fixed.
And finally, the lower brainstem. Gag and cough
You
reflexes.
stimulate the posterior pharynx or suction down the endotracheal tube. This tests cranial nerves IX and X. In brain death, there's no gag, no cough, nothing.
Okay. If all of those reflexes are absent, we move to the ultimate confirmator, the apnea test.
This is a high-risk test. It's not just turn off the ventilator and see what happens. Explain the principle first.
The principle is simple. We need to prove that the respiratory center in the medulla is dead. The strongest physiological stimulus for breathing is a high level of CO2 in the blood. So we intentionally let the CO2 rise to levels that would force anyone with a living brainstem to take a breath.
And how do we do that safely? The procedure.
First, the prerequisites must be met again, normothermia and normotension. Then you pre-oxygenate with 100% oxygen for at least 10 to 20 minutes. We do not want them to become hypoxic during the test, only hypercapnic.
Right.
Then you disconnect the ventilator. But, and this is the key safety step, you keep giving oxygen. You place a catheter down the endotracheal tube with a continuous flow of oxygen, which we call apneic oxygenation.
So we're letting the CO2 rise from their own metabolism, but we're keeping their oxygen saturation safe.
Exactly. We wait, we watch the chest and abdomen intently for any sign of respiratory effort, and we're aiming for a target PaCO2 of over 60 millimeters of mercury, or at least a rise of 20 from their baseline.
And if there is absolutely no respiratory effort, despite that massive hypercapnic stimulus,
The test is positive, brain death is confirmed.
what if the blood pressure plummets or the SATs drop during the test?
Abort immediately. Reconnect the ventilator. The patient's hemodynamic stability comes first. You cannot destroy the viability of the donor organs just to prove death. You can always try again later when they are more stable.
Good. Now, what about confirmatory tests, ancillary tests? I know they use them a lot in some countries.
Right. In the UK and India, the clinical diagnosis is usually considered sufficient. We only use these ancillary tests when the clinical exam is impossible.
Like if the patient has severe facial trauma and you can't access the eyes to test pupillary or corneal reflexes.
Exactly. Or if there's a confounding factor you can't clear, like a patient with a massive barbiturate overdose whose drug levels are still sky high.
So what are the main tests?
The gold standard is a 4-vessel cerebral angiography. You inject a dye. It shows absolutely no blood flow entering the skull beyond the carotid bifurcation. The brain is swollen shut. There is no intracranial circulation.
That's pretty definitive.
It is. Then there's the EEG, looking for an isoelectric or flat line, but its limitation is that electrical silence in the cortex doesn't definitively prove brainstem death.
And the third one?
Transcranial Doppler, or TCD, you use ultrasound to look at the arteries at the base of the brain. In brain death, you see a characteristic pattern of reverberating flow, or diastolic flow reversal. The blood goes up, hits the high pressure in the skull, and literally bounces back down.
Okay. Excellent. Now, the medico-legal aspects. This is a very high-yield topic for the Viva.
The ethical bedrock is the dead donor rule. You can only retrieve organs after death has been legally and formally declared.
And who declares it?
It usually requires 2 doctors. Under the THOA Act in India, there's a specific panel, typically the intensivist or neurosurgeon in charge of the patient, and another specialist who is approved by the hospital board.
And they have to do the test twice, right?
Correct. They perform the full set of tests twice, usually with a time interval of around 6 hours in between, just to be absolutely certain there's no change. And this is crucial, they must not be part of the transplant team.
That separation of interest is vital for public trust and ethics. The team trying to save the patient cannot be the same team looking to retrieve organs.
Absolutely. Okay, so the patient has been declared brain dead. They are now an organ donor. The goal immediately shifts from cerebral resuscitation to organ preservation.
We're managing the aftermath of that catecholamine storm. We want healthy, well-perfused organs for the recipients. What's the rule of 100s?
It's a handy mnemonic for our goals. Keep the systolic blood pressure 100, keep the PO2 100, and keep the urine output around 100 milliliters per hour.
And physiologically, what are the main problems we're treating?
First, the vasoplegia. The sympathetic tone is gone. You need to give volume fluids first and then start vasopressors, usually noradrenaline or dopamine. We try to use the minimum effective dose to spare the kidneys and heart from excessive stimulation.
And second, the endocrine failure. This is the more sophisticated part of the management, the hormone resuscitation protocol.
Right. The pituitary is dead, the thyroid storm from the initial injury is gone, and now you have a massive deficit. The heart, in particular, needs T3 to function efficiently.
So we replace it.
We give T3 or T4 to improve cardiac stability and reduce the need for inotropes. We give a stress dose of steroids, like methylprednisolone, to dampen the massive systemic inflammatory response that's going on.
And we treat the diabetes insipidus.
With vasopressin or desmopressin to stop them from peeing out their entire blood volume. This hormone cocktail has been shown to significantly improve the number and viability of the organs recovered for transplant.
Okay, before we wrap up, I need the Viva traps. The tricky questions the examiner will use to trip me up and make me look foolish.
Okay, trap number 1, spinal reflexes.
Yes.
You've declared the patient brain dead. The family goes in to say their goodbyes, and the patient's hand moves. Or they have a Lazarus sign. The arms flex and cross on the chest. The nurse screams, "Is the patient alive?"
No,
Yeah.
this is terrifying, but it's physiological.
Exactly. The spinal cord is still alive. It has its own segmental blood supply. It can generate its own reflexes independent of the brain. The brain is dead. The spine is not. You must not confuse these spinal movements with brainstem function.
And you have to warn the family that this might happen.
You absolutely must. Okay, trap number 2, the atropine test.
You give a dose of atropine. Normally, the heart rate should go up, right?
By blocking the vagus nerve, yes. But in brain death,
The vagal nuclei in the medulla are dead, so there is no vagal tone to block in the first place.
so atropine does nothing. The heart rate stays fixed. If the heart rate goes up after atropine, the brainstem is alive. If it stays flat, it supports the diagnosis of brain death.
Okay, good one. And trap 3, the pupil size.
Right. Everyone assumes the pupils must be maximally dilated, like 8 millimeter wide, but that's not true.
They just need to be in a mid position or dilated and completely non-reactive to light.
Yeah.
Don't fail the patient just because their pupils aren't huge. Fixed and mid position is perfectly compatible with brain death.
Excellent. Finally, visuals. In a theory paper, diagrams get you marks. What are you drawing?
For part A, I'm drawing the synaptic cleft, showing the vesicles, the calcium influx, the release, and definitely the GABA-A receptor complex, showing the 5 subunits and labeling the binding sites for propofol on the beta subunit and benzos at the alpha-gamma interface.
Good. And for part B?
The brain death pathophysiology timeline. A simple flowchart, high ICP, catecholamine surge crash, and another flowchart for the apnea test protocol, step by step.
That is a winning strategy. So let's summarize this massive deep dive for the final revision.
Go for it.
1. Neurotransmitters are classified by structure means, amino acids, and by function excitatory or inhibitory.
2. GABA is the king of anesthesia inhibitory. Glutamate is the king of excitation excitatory.
3. Our anesthetic drugs work by potentiating GABA, which opens the chloride gate, or by inhibiting NMDA, which blocks the glutamate gate.
4. Brain death is irreversible brainstem failure. It is not coma, and it is not a vegetative state.
5. The diagnosis requires you to meet all the prerequisites first, then demonstrate the 3 pillars: coma, absent brainstem reflexes, and a positive apnea test.
And 6. Once declared, management shifts to organ preservation. You fight the vasoplegia and the endocrine failure using the rule of 100s and hormone resuscitation.
And my final tip for the exam: in the Viva, do not rush to the apnea test. Spend time explaining how you meticulously excluded all the reversible causes first. That is where they fail you. If you even suggest doing an apnea test on a hypothermic patient, you have failed the station. Be methodical, be safe.
Professor, thank you. That was the high-yield, structured review I desperately needed. I feel like I can actually tackle these questions now without just panicking.
You have all the knowledge. Just visualize those diagrams, review your hospital's specific certification forms and checklists, and go in there with confidence.
To our listener, the MD candidate staring at a pile of books right now, good luck with the exams. Breathe deeply, recall the physiology, and you've got this.